Hold on. It stopped working. Okay, so good morning, everyone from Indiana University, for the people in the US, and also good evening, people in Thailand and in the Southeast Asian region. Today is the second episode of the collaboration between Indiana University and Imaging Academic Outreach Center. And today, so this series is a lecture series in pediatric neuroimaging, which we have done 2 times already in Thailand, and this is the third season of these lectures. The first time we did this lecture series was in 2017. Second time was in 2019, and when COVID hit, we cannot have any lecture series in Thailand in pediatric neuroimaging. So this time we use the regular lectures that we do for our trainee in US and bring it up, broadcast from Indiana University to the people in Thailand and Southeast region country. And the second episode of this lecture series is about mTOR and tubulinopathy, which one of the famous speaker that has a fan base in Thailand, and also the teacher of the year from Indiana University 10 years in the row. I think it's more than 10 years, 12 years already in the row. So, and we also have the moderator from Thailand, Dr. Namphon Tavi Asani, help me moderating this session. So please welcome Dr. Wu to the lectures. Yay.
I'm going to start to share the screen here.
Yes.
Okay, can you see the screen okay, like this?
Yes, we can see the screen, and we can also see the arrow. Yes.
Okay, great. So so let's get started. Hi everyone, my name is Isaac Wu. I'm a pediatric neuroradiologist and adult neuroradiologist from Indiana University. So good morning everyone from IU, and good evening everyone in Thailand and Southeast Asia. So thanks for tuning in. You can see the topic today we're going to talk about is mTOR pathway disorder and tubulinopathy. They are unrelated, or they're loosely related to category disease. So why are we talking about them together? So I have an underlying theme that I think is going to tie things together. So let's just get started. And for the purpose, so if for some reason the audio is not transmitting, because last time I think we have a problem with that, just let me know. Okay. And also, if you have any questions, please feel free to pause and ask me any questions if I'm not making it clear, or if you have any question, or you can email me later if you feel more comfortable. So for the purpose of CME, I don't have any, no conflict of interest to disclose. So let's talk about these 2 disease subcategories. So why are we talking about both of them? So I think the whole theme here is we are going to talk about is essentially the topic of genomics. So if you think about just a basic definition for genomics, and we talk about genetics, genomics, according to WHO definition, the genetics really is just study of a single gene, its function, its composition. Whereas genomics, that we are looking at the entire system, we're looking at all the genes or group of genes, their interrelationship and their growth, how do they affect the development and the influence on an organism and an organ. So it's much more holistic picture. So that's the term genomic. And this is not something new, right? This is something that we have always sort of strived for with medicine. We are getting better at it. And we all heard about gene therapy, targeted therapy. And that's where the medicines go in to become more specific about treating specific pathway, rather than just shotgun approach, treat the entire system, causing a lot of undesirable side effect. And that's the direction it's going, the medicine is going, and that's also the direction that radiology is going. So as radiologists, we should be able to keep up with this new trend. So genomics, what about us with genomics? So radiology with genomics. So that's where the radiogenomic is coming from. So radiogenomic basically is that what we see in radiology, what do they look like on imaging? Can we predict not only their histology, but also their genetic makeup? So that's sort of the holy grail of what we're trying to do. And that's a direction that I think radiology is also going for. In the past, actually still is today, our gold standard, as everyone knows, for radiology is radiology and pathology correlation, right? RAD-path correlation. And that's a reason why we send trainees to Washington, D.C. Every year for 4 months. Once during your career, that you go to the, used to call AFIP, I forget what it's called right now. You do this big conference, your correlation between radiology and pathology. So that is our gold standard. That still is our gold standard. So for example, in this image right here, you have a 6-year-old child, pediatric child coming with ataxia. On this T1 post-contrast sequence, you can clearly see there's a midline lesion within the fourth ventricle, heterogeneous enhancement, central necrosis. Looks kind of ugly. So what is your differential diagnosis for pediatric posterior fossa tumor? Right. So for trainee, you know that you're big three, right? If you think about pediatric midline fossa, pediatric posterior fossa tumor, you think about medulloblastoma, which is WHO grade 4, versus ependymoma versus pilocytic astrocytoma. That's WHO grade 1. Ependymoma is grade 2 and grade 3. If the patient's younger, say 2 years or younger, you think about ATRT. So that's your differential diagnosis. Then you look at the image based on what you look like on diffusion, perfusion, T2, post-contrast. Then you come up with your top differential diagnosis. In this case, I think this is medulloblastoma. Then patient, and hopefully not autopsy. This is a picture coming from internet, but patient go under surgery and you get a sample resection or biopsy. Then pathologists look under microscope and make their histologic diagnosis. And indeed, this come out to be medulloblastoma. So that's correlation between radiology and pathology. That is our gold standard. That has always been our gold standard. So RAD-path correlation. But more and more, we are going to rely on histology, more than just histology, but molecular definition of what the pathology is. In some cases, the molecular makeup would trump the histological diagnosis. For example, oligodendroglioma that I will show you in a little bit. The newest classification from 2021, the 5th edition of the WHO grade CNS tumor, still define 4 molecular defined subtype for medulloblastoma. In the last edition in 2016, there's a group 3 and group 4. Now we just lump them together. So the question is that, are we able to correlate with what they look like on radiology, then predict not just the histology, but also the genomics? The answer is that we're getting better at it. For example, in this case, there are certain look to this histology in midline, and this look like group 3 or group 4. The difference is that for group 3, they tend to enhance, and group 4, they tend not to. So in this case, we look at the radiology, we predict that this is medulloblastoma with the molecular group of group 3. And then they do an analysis, sure, indeed, this turned out to be group 3. So that's the correlation between radiology and genomics, so radiogenomics. Just quick recap. I know that this is something we're just getting comfortable with back in 2016, the CNS tumor classification, but the newest classification coming out is 2021. Now it's 5th edition. For medulloblastoma, it's still quite similar. For the first time in 2016, molecular definition of molecular biomarkers introduced to the classification. For 2021, that plays an even bigger role. So again, the genomics is going to be more and more important when it comes to diagnosis. And that, of course, can also affect what we do in radiology. So if you look at the current edition, the medulloblastoma is still similar. There are 4 molecular defined subtypes. There are multiple newer subgroup underneath that. And notice that previously we have a histologically defined medulloblastoma. Now we just put that under one large category. Let me show you another example for radiogenomic, right? So you see these 2 images right here. Now, you have a T2 weighted image right here and flare, corresponding flare. There is a intraaxial lesion. On T2, it looks very homogeneous, very bright on T2. So look like a low-grade lesion or hypocellular lesion. And if you look at the flare, though, I would contest that the flare does not quite look like T2 in the sense that you have a bright rim of T flare signal outside, and inside is hypo-intense. So in other words, it doesn't look like homogeneous like T2 weighted sequence. So that was referred to as T2 flare mismatch. And for that, it's fairly specific for 1p19q non-co-deletion status. So in other words, this is an astrocytoma rather than oligodendroglioma. For oligodendroglioma, it's going to be 1p90q co-deletion. So if you see this mismatch sign, and that's fairly specific for, according to multiple papers, fairly specific for 1p19q non-co-deletion status. So again, using radiology, try to predict what the genomics is going to be like. And these are some of the representative paper talk about this phenomenon. It's pretty specific, but unfortunately, it's not very sensitive. So in other words, there are many tumor doesn't have this appearance. But if you do see this mismatch, again, kind of similar to what I just showed you earlier, and this T2 homogeneous T2 weighted image versus a heterogeneous flare. And this is the example coming from our own institution at IU. For this case, this is a 25-year-old male. Again, you see an intraaxial expansile lesion. So if you look at T2 is kind of homogeneous in appearance. And if you look at the flare, I would say that this looks more matched compared to previous example that I showed you that's more mismatched. So for that, I would call this T2 flare match. And therefore, this is likely a 1p19q co-deletion. And then the patient went to surgery, resection. Sure enough, histology and molecular biomarker indeed show that this is a 1p19q co-deletion. So the final diagnosis, oligodendroglioma, so not astrocytoma. So that's another example of what radiologists can do, look at the image and make the prediction of not just histology, but what the final diagnosis based on the genomics may look like. And we are getting better at it. So for comparisons, oligodendroglioma, there's a big change between the last classification versus the most recent classification. And one of the biggest changes that we no longer use the term anaplastic. Excuse me. Previously, as you know, a grade 3 tumor is called anaplastic something. Like in terms of oligodendroglioma, it's grade 2. And if it's grade 3, you call that anaplastic oligodendroglioma. Astrocytoma, grade 2, grade 3, that's anaplastic astrocytoma. You no longer call that, you just give them grade. Another big change that between the current and the last editions that we no longer have secondary glioblastoma. Last time, the IDH mutant is called glioblastoma, grade 4. But now we just call that astrocytoma, grade 4. So that's another major changes among different iterations. So when you look at the grading of the tumor, in the past, histology is the most important. It still is, of course, play a very important role. Then we assign a WHO grade 1, 2, 3, 4. And then now you account for the molecular information and you have an integrated diagnosis. In some incidents like oligodendroglioma, the molecular information trumps the histology. So in other words, the pathologist may look at the microscope and say, this looks like oligodendroglioma. The radiologist may look at the image and say, this looks like oligodendroglioma. But if the molecular analysis shows that it does not have 1p19q co-deletion, then it is not oligodendroglioma, it's astrocytoma. And this is not just academic, right? It does affect the overall prognosis, and more and more importantly, increasingly, it affects the overall treatment. So it's an important distinction. And this will be the example. The histology, the pathology, look at a certain slice and see a diffuse astrocytic tumor with mitotic figure. And based on the different analysis, the mitosis, the vascular proliferation, necrosis, etc., they assign a WHO grade 3. So it's still not the worst one, right? Not grade 4, it's grade 3. Then they do their molecular analysis and they found that various markers positive for grade 4, and that would be upgraded to grade 4. Now that becomes GBM. So that's the approach that we're going. Again, just to recap, in 2007, the 2 editions ago, the diagnosis is essentially just based on histology. For example, you have grade 2, grade 3, and grade 4. And grade 4, you'll be your GBM, the glioblastoma, the worst kind, right? Grade 2 is astrocytoma and versus oligodendroglioma based on what they look like on the microscope. So therefore, there are times that there are some tumors that will look at the mixed feature between oligodendroglioma and astrocytoma, and that was referred to as oligoastrocytoma. And that is very, very subjective. So in other words, in some institution, oligoastrocytoma is a very, very common diagnosis, but in some institution, oligoastrocytoma is rarely diagnosed. So just based on histology, what they think that there's a mixed feature. And that has changed since the introduction of some of the molecular markers in 2016. So make things much more definitive. So the IDH 1-2 was introduced. And at that time, you look at the IDH status. If it's mutated, then you look at the status of 1p19q co-deletion. If that's present, then you have a diagnosis of oligodendroglioma. If it's grade 2, if it's grade 3, that's anaplastic oligodendroglioma. And notice that no longer they make the diagnosis of oligoastrocytoma because now you can just look at the molecular marker and make your diagnosis. So that makes things much more clear. If the status no, if there's no 1p19q co-deletion, then that is astrocytoma. Again, grade 2, astrocytoma, grade 3, anaplastic astrocytoma. And grade 4, that's your secondary GBM. So you have IDH mutant grade 4 astrocytoma, that's your secondary GBM. Then if it's IDH is wild type, then you have grade 2, grade 3, and grade 4, that's your primary GBM. Right? Now comes to the newest edition last year, the 5th edition. The pathway still is the same. You look at the IDH status. If it's mutated, you check the 1p19q co-deletion status. If that's positive, again, that's oligodendroglioma. Grade 2, the difference is that instead of calling anaplastic astrocytoma, now the terminology anaplastic something no longer is in the vocabulary. So we just call that grade 2 and grade 3. If the 1p19q co-deletion is negative, then that's astrocytoma. Again, previously, grade 3, you call that anaplastic astrocytoma, but now you just call that grade 3. Previously, if IDH mutant by grade 4, that is GBM. And in other words, secondary GBM, secondary glioblastoma. So we think that that's evolution or progression from a lower grade tumor progress into GBM. That vocabulary no longer exists. You just call that astrocytoma IDH mutant grade 4. So you don't have a secondary GBM anymore. For the wild type, again, you have the lower grade IDH wild type astrocytoma. If it's grade 4, that's your GBM. That's your primary GBM, IDH wild type. The interesting thing, or not interesting thing, but the thing is that, again, some of the molecular biomarker now trumps the histology. So you may have something that look on histology look like grade 2 or grade 3. But if one of the marker or multiple marker that's positive, then you may make the diagnosis of GBM, grade 4, even though some of the histology looks relatively benign. That is a little bit problematic. In fact, that's very problematic for radiologists too, right? Because you can look at a tumor may look relatively benign, Brion T2, no restricted diffusion, so it does not look like hypercellular tumor, even perfusion is negative. So if you ask me 100 times out of 100 times, I would call that a low-grade tumor. But when they go to do their molecular analysis, this biomarker is positive, and that's upgraded to GBM. So a benign looking or low grade looking tumor now has potential to become a high grade lesion. So that is problematic for radiologists. Fortunately, most of the cases right now still is not like that. So we still have to go with what we know. But the direction may be going that we can find some other radiographic feature. Chances are probably coming from something that's more advanced, such as Dr. Veronese is doing his FAT PET and other type of radiology method that can help us determine more accurately the radiogenomic of the final diagnosis. So that's just something to keep in mind. Again, why is that important? It's important because the prognosis and the treatment is different, right? For the IDH mutant and IDH wild type, for both astrocytoma and GBM, we know the survival rate. This is a chart for GBM, grade 4. We know the survival rate is quite different between, even though both of them, at least in the last edition, both of them are referred to as glioblastoma, but the survival rate for wild type is significantly different than the mutated. So the mutated secondary ones usually do much better. So that's for tumor, but we are not going to focus about tumor. That's a long introduction about the whole thing, but we are going to focus on malformation today. So the question is that, can we use radiology? Is there radiogenomic for malformation? The answer is much more complicated. Well, even with tumor, we are still working on it. We're getting better at it, but still there's a lot of, obviously this is something relatively new. But the problem with malformation is that, first of all, there's cascade effect. So in other words, if you see something that occurred very early on in embryology, in the fetal development, that has potential to affect multiple organs downstream or multiple development, neural development downstream. So that's why when you guys come to Riley for your pediatric neuroradiology rotation, I always encourage you to look, if you see a malformation in one place, look harder for elsewhere, because there's a good chance that the second malformation is there that we are not seeing it. So the cascade effect. So that make it difficult in that different gene may give you same pathology phenotype. For example, we look at something that look like polymicrogyria, and that is just a phenotype. So in other words, it can be affected by multiple different disease process that's created by different gene mutation. On the other hand, same gene can cause different phenotype, the end result. So for example, tubulinopathy, that's one thing we're going to talk about today, is that you can have multiple gene or same gene that can affect, give you a different look. So different disease may have the same origin. And there are a lot of overlapping features. So that's making radiogenomic much harder for malformation. So that is the kind of the overall pictures. Any questions so far? I hope you guys are still awake. All right, so let's talk about the first category you're going to talk about is the mTOR pathway disorder. For those of you, many of you probably never heard this before, especially you haven't really do pediatric neuroradiology, but I guarantee you, if for the trainees also, that you have already seen many of these disease processes. And this is something that you're going to need to be aware of, because even if you're not going to neuroradiology, this type of question will come out in your board exam. So mTOR pathway. So what is a mTOR? mTOR stands for mammalian target of rapamycin. The key word here seems to be rapamycin. So rapamycin is a protein that has an immunosuppressive effect and also has an anti-neoplastic effect. The reason why it's called rapamycin, it was discovered in the island, isolated from a bacteria in the soil in the bacteria in this island called Rapa Nui, hence rapamycin. And it was actually discovered a long time ago in 1964. So Rapa Nui is this little island off the coast of Chile. I think all of us actually know about this island. We just call it by a different name. That's an Easter Island. So you've seen the picture like that before. And in fact, apparently there's a plaque that's celebrating the fact that rapamycin was discovered on the island. Rapamycin also become a little bit gain notoriety among the general public a few years ago because it was touted as its anti-aging property. So you have some of the public press talk about potential cure for aging, like the forever pills, for example, they're talking about. So can rapamycin help humans live longer? One of the company that holds the patent for Rapalox, and that's what they're talking about, potential anti-aging drugs. And of course, that's like every other news that's typically overblown. But what's more exciting is that mTOR has been approved for treatment of a certain type of mTOR pathway pathology. So what is mTOR pathway? If you look at this very, very complex, some of you may even have studied this in biochemistry or in undergrad. So in this complex pathway, the central theme, of course, is mTOR complex 1. So it's a complex 2, but we're going to focus on mTOR complex 1. And the pathway, the whole pathway is sometimes referred to as PI3 kinase AKT mTOR pathway. So it starts with a tyrosine receptor tyrosine kinase. You have a stimulated by growth factor. The growth factor in turn triggered the first pathway, PI3 kinase, and that have stimulated, in fact, to AKT or protein kinase B. And that in turn has an inhibitory effect to tuberous sclerosis complex 1 and 2. And that has inhibitory effect of the mTOR. So that's kind of the entire pathway that you're looking at in a more simple term. So more simply put, the role of mTOR is to take in all this feedback or this stimulation, growth factors, oxygen, energy, nutrients, and they have serves two functions. One, it inhibits the apoptosis, and the other one, they can stimulate the growth of an organ. So all the protein synthesis, nucleotide synthesis, and promotes the growth of a cell or organ. So basically, they stimulate the growth and they depress or they inhibits apoptosis. So the end result is that mTOR would facilitate the overall growth of cell and the organ, and that's mTOR. Now, what if mTOR is out of control for some mechanism, whether this local inhibition or overstimulation? What would happen? Well, of course, you would have a growth that's out of control. So therefore, you have cells or organ that will become malformation, either as a tumor or overgrowth malformation. So that's kind of the underlying theme for mTOR pathology. So you're going to have various disease processes that can cause either overgrowth or tumor formation. So some of the more common one, representative ones that is listed right here, and we're going to talk about a few of them, and the one that's more commonly that you will come across at Riley, and also some of the study for the Chinese that you will come across for your board exam. So let's talk about some of this particular pathology. And let's start with, what if you have multiple pathways that's affected? So either in the beginning or toward the latter part. So of course, you have a tendency for overgrowth tumor problems. By the way, not surprisingly, or should not be surprised to you, that if there's a mutation that's blocking this pathway, you may have undergrowth. So in other words, you can have microcephaly. So let's start with the first case. I'm going to unfortunately pick on the Chinese a little bit. Who is on pediatric neuroradiology right now? You know, actually, tell you what, I'm going to pick on Stephen. Stephen, are you there?
Yes, I'm here. Can you hear me?
Okay. Yes. Yes. Here. So do you mind just quickly describe what you see here?
Yes. In the left occipital lobe, there's some cortical thickening, some pachygyria. It looks like there's some subcortical heterotopia kind of between the cortex and the left, the occipital horn of the left lateral ventricle. There's also some migration anomalies. It looks like in the left frontal lobe and likely along the insula there as well, although it's kind of ill-defined but very thickened.
Good. And do you have a guess as to the overall diagnosis is? And
there's
also, do you think one side of the brain is bigger than the other?
Yes, I think the left side of the brain is bigger, and these are all forms of cortical dysplasia.
Okay, good. So perfect. So you're absolutely right. So first of all, you do see there's one side of the brain is clearly larger than the other side. And as you nicely described, there are multiple malformations that you can see, thickened cortex, etc. And in fact, all the left side of the brain is abnormal. Now, the interesting thing is that you also notice that the side that's enlarged also has enlarged ventricle compared to the relatively normal size. So you probably would never confuse this with other entities, such as say, what if you're thinking about this side is abnormal? I mean, you shouldn't think of that, but let's say you do. Say if you're worried about atrophy of one side of the brain, or maybe you're worried about a diffuse tumor that's growing on the left side of the brain that's making it larger. Previously, for example, we used to call things like this the gliomatosis cerebri. The thing is that, and this is something that they ask on board exam, by the way, is that notice that if this is atrophy, the site of volume loss tend to have enlarged ventricle. So you have exvacuole dilatation of the ventricle, right? The sites that's enlarged by tumor, you should have a mass effect against the ventricle. So the ventricle should be smaller. So for hemimegalencephaly, which this disease process is in essence, it's kind of like a large or diffuse cortical dysplasia. The side that's affected, the enlarged sites, has also enlarged ventricle. And then, Stephen, you said very nicely that there are multiple malformations that you can see. So basically, entire brain on the left side looks abnormal. And if you look closely, which you cannot really see very well, sometimes on the right side, you also affected more focally. So this is hemimegalencephaly, HMEG. It's one of those overgrowth process that affects the mTOR pathway. Various location mTOR pathway can result in this. Again, not surprisingly, because of the mTOR is stimulating overgrowth. So unfortunately, there's no cure to this. It's just mostly symptom control. Patient, as you can imagine, has a epilepsy or seizure that's out of control. So that's a basic sort of the point about the care is to make sure quality of care or quality of life is good. If early young, sometimes you can, this is different patient right here, they can just take out the abnormal side if the patient is young. The things that other than surgical outcome is people start looking into mTOR inhibitors because of the pathway. So again, understanding of pathway is important not only for the diagnosis, but also for the prognosis and treatment. So various pathway can affect things like hemimegalencephaly, overgrowth of the one side of the brain. What about something, so you can have then some consider that this may be a spectrum, right? From cortical dysplasia very, very locally to something that's more regional. So you have affect one side of the brain. So you have hemimegalencephaly. Very rarely you can affect the entire brain, cerebellum, bilateral cerebellar hemisphere, and that's a DMEG or dysplastic megalencephaly. Something that I have not seen in a real life cases, but it's pretty rare. What about if something that affects the mTOR complex itself? So you may have something that is like this. Who is the resident on pediatric neuro right now?
That's me, Dr. Wu. This is Tyler.
Oh, Tyler. Hi, Tyler. Good morning. Can you quickly describe what the arrow sign tells us?
It looks like it's pointing at some T2, or sorry, flare hyperintensity, right frontal lobe involving the cortex.
Good. And do you have a diagnosis? Let's say this thing does not enhance.
So I think it does look thickened. I mean, it could be cortical dysplasia.
All right, so very focal, right? So good. So this is focal cortical dysplasia. Nice. Sometimes you can see this thing, the radial band or band of linear. You may have seen this already. I know this is day 2 or first week of your rotation, that you may have come across a focal cortical dysplasia. And sometimes you can see this linear line that extending from the ventricle toward the cortex, the transmental sign. It's more common in type 2B, and this type tend to have better surgical outcome. Now, this is focal cortical dysplasia. Again, there is a spectrum between that and expansion into something more regional and maybe more global, like the hemimegalencephaly. Histologically, they looks very similar or essentially identical to the cortical tuber that we see with tuberous sclerosis. The difference that is the focal cortical dysplasia does not calcify like some of the cortical tuber in tuberous sclerosis can, but with with tuberous sclerosis, sometimes you can also see this transmental sign or this linear signal that's extending from the ventricle to cortex. So the focal cortical dysplasia that you can present as more focally overgrowth and a regional or global overgrowth that affect one side of the brain. What about the one that affects the one step before before the mTOR complex 1? So there's in the the mTOR complex 1 is inhibited by tuberous sclerosis complex 1 and 2. Again, if something's interfering with this particular protein, then you can imagine that the suppressive effect would be decreased or dysfunction, and that can cause mTOR going out of control. Again, cause overgrowth problem. So this, you will come across some pathology that look like this with a relatively classic picture. Let's say West. Wes, are you there?
Yeah, I'm here. Can you hear me?
Oh, yes. Good morning.
Morning.
So can you describe for us what you see on these images?
Sure. So 3 axial images of the head, 1 a CT, 2 axial MR images, T1, probably post-contrast enhanced, and then a axial flare. So on the CT, you have these areas of abnormal calcification in the region of the right caudate head, and then also abnormal calcification posteriorly, maybe maybe right occipital lobe, or I'm not sure if we're actually down lower and I'm seeing cerebellar calcifications. But and then on the MR images, you can see there are these nodules along the ventricular margin that enhance. And then on the FLAIR image, you can see that there's areas of cortical thickening, blurring the gray-white junction, and areas of increased signal sort of deeper at the sort of subcortical, juxtacortical region. So, yeah, pretty typical tuberous sclerosis.
Excellent. So a wonderful description. For younger trainee, that this is something that will come across on your board exam. So you need to be familiar with the classic appearance of a tuberous sclerosis. Like everything that Wes just described are the common feature of tuberous sclerosis. So in this case, you have a calcified subepimpinal nodule. Not all of them will calcify, but many of them can. The cortical tuber and subcortical tuber can also calcify. And this is a subepimpinal nodule, and many of them can enhance. The enhancement itself does not signify that this is a higher grade lesion, by the way, or SEGA. I will show you the subepimpinal giant cell astrocytoma. There are multiple cortical and subcortical tubers. Tuber just means potato, so hardened tissue. So this is a classic picture of tuberous sclerosis. So something that you need to be aware for board exam. So even if you never heard of mTOR pathway pathology or mTORopathy, some people refer to, most of us are very familiar with tuberous sclerosis. Right? So as you know, this is part of the phygomatosis. So phygomatosis, the neurocutaneous disorder, is a very, very public subject for board exam, right? Because they can ask you things about neuro stuff. They can ask you about body stuff, right? They typically affect multiple organ processes beyond just neuro. It's a tumor suppressor gene. We talk about tuberous sclerosis complex 1 and 2, and that has inhibitory effect to mTOR complex. And we talk about some of the more common feature or classic feature for tuberous sclerosis, such as subcortical tubers, subepidermal nodules. Many of them can calcify. And sometimes you can see similar to focal cortex dysplasia type 2, you can see that radioglial band. Some patients can progress into subepidermal giant cell astrocytoma. So this is an example of a SEGA, or subepidermal giant cell astrocytoma. It's a low-grade lesion. It's a WHO grade 1. It's essentially happened only in tuberous sclerosis patient. In other words, if you have a tumor that was biopsy or resected and the pathology is subepidermal giant cell astrocytoma, but patient does not have tuberous sclerosis, that is quite uncommon. But only small minority of patients with tuberous sclerosis can have SEGA. So the diagnosis basically made based on size, location, and the growth rate. So this is a classic example of SEGA in a 12-year-old patient that has a known tuberous sclerosis complex. And this one, in this case, is greater than 1 centimeters already. And it's in the location that's at the foramen Monro or near foramen Monro. Contrast that to subepidermal nodule. They are less than 1 centimeter, and many of them do not enhance as avidly as SEGA. Again, enhancement itself for subepidermal nodule does not mean that the patient has SEGA, by the way. So many of the subepidermal nodule, especially on MRI, shows enhancement. And we follow this lesion every year. So sure enough, the lesion continued to grow. And essentially grow and also develop a cystic component because it's location by foramen magnum that tend to cause obstruction. So essentially you have to take them out. And in this case, it was taken out and the pathology was confirmed to be SEGA. The treatment for SEGA, of course, is surgery, especially when you have obstruction like this, you need to take it out. But more importantly, now we have also medical treatment. So in terms of you can do inhibition of mTOR inhibitor with rapamycin or Rapalog, the analog to rapamycin, right? The forever pill that people were talking about earlier. Not only that can help with SEGA, but they can also normalize other pathology in the mTOR pathology in tuberous sclerosis complex, so such as renal angiomyolipoma. Again, the phygomatosis, the neurocutaneous syndrome, is a very public topic for board exam because they can ask you neuro stuff, they can ask you body stuff. It can also help with tuberous sclerosis complex related epilepsy, and as well as LAM. Now, it has been approved by FDA to treat multiple symptoms related to tuberous sclerosis. This is one of the paper that review paper talk about the beautiful result specifically for SEGA with rapamycin. You can see that long-term outcome is great. So the tumor continues to shrink after 6 months, and on the long-term maintenance is getting smaller and smaller. Unfortunately, with SEGA and with seizure, for example, there's a rebound effect. In other words, if the patient taken off the medication, the SEGA will come back. They grow back, getting bigger, and the seizure frequency will come back. So the treatment right now, this is a long-term treatment. So patient need to be on Rapalog for long-term. So it's still not a cure, but at least that's something that's better than in the past where there's not much to do other than surgery. So that's a tuberous sclerosis, again, belong to the same pathway. And lastly, also some of the processes that affect the P10, you can have a tumor suppression. This is tumor suppression that's out of control. For example, you can have something look like this. let's see, is there another, Tony, can you take this one?
Yes, sure. So we have 3 axial cuts. It looks like there's a mass centered in the left cerebellar hemisphere, causing mass effect in the 4th ventricle. It's not terribly avidly enhancing from what I can see, but I think it's a little bit level up. It kind of has like a striated appearance, I would kind of say, maybe a little bit.
Yes.
So just like the Lermite Duclos.
Very nice. Very nicely done. So great description, Tony. So the key thing here is that if you think about this mass lesion, clearly expansive mass lesion, mass effect on the 4th ventricle, like Tony was describing, look like a tumor, right? What's kind of unusual or unique about this being a neoplasm is that neoplasm or tumor, if you think about posterior fossa tumor, that have a tendency to essentially kind of obliterate the sulci, right? The fact that you have preservation of this sulci and striation, and that in itself is relatively uncommon for a tumor, right? Or a neoplasm. Typically, Lermite Duclos does not have a lot of enhancement. Classically, they should not enhance. They can, but on board exam, they often show you one that does not enhance. Also, it's not hypercellular, like some of the higher grade tumor, like, for example, medulloblastoma, they would show restricted diffusion and signify hypercellularity. So this typically do not have restricted diffusion. So this is dysplastic cerebellar gangliocytoma, also known as par French Lermite Duclos disease. It's a WHO grade 1, so there's a debate as to are they truly neoplastic or are they malformation or both, right? And in adult with other P10 tumor, you have other like Cowden disease, for example, the other tumor producing syndromes that they together they are called the co-syndrome. So that's the part of the pathway. So basically, you have a same pathway that produce quite a different look. So it's kind of the old saying, right? These something that's always new again. It's like in the past we have split. We have people who are lumpers. We have people who are splitters, and we may initially discover a disease processes, and then we just think there are a couple of disease, so we lump them all together as one pathology process, and then we start to see them differently. Say within the same category, they may have a separate different, so we split them again, and now we realize that many of them may belong to the same pathway, so we are kind of lump them back again together again. Again, the pathway would affect the overall prognosis, and increasingly, as you can see, there are more specific targeted treatment. So that's a reason why it's also important for radiologists to keep up with some of the molecular information or pathways. So that's the first category. Any questions so far? Okay, good. And at the end of this lecture, if you have any question, please feel free to email me, and I'll give you my email address afterwards. By the way, you can buy some of the supplements, the Rabalog on eBay, or not eBay, Amazon, I think. So this one they call about, remember we talked about the anti-aging effect, and this one because of the stimulation of overgrowth, and some people try to use that to build your muscle. So for those bodybuilders, you can go on Amazon and buy a bottle of this. Experiment on yourself. But I probably wouldn't trust a company that call themselves Super Smart or I'm So Alpha. I don't know, just me. All right, so let's switch to a different category disease. And this is much more rare or much less common than mTOR pathway pathology. So again, mTOR pathway pathology, even though the term mTORopathy may be unfamiliar to you, many of the disease processes that it is not that uncommon, especially for if you study for board exam. And when you're over at Riley, you will see many of the mTOR pathway pathology. But tubulinopathy is something that's much less common. But nonetheless, that's a common thing about different pathways that we should be talking about. And sometimes you can come across the board exam that would look like this, right? There are two separate patients here. everyone can relax. I'm not going to pick up any training for this particular category because it's relatively uncommon disease. So just sit back and relax. So this is a patient A is a 6-year-old male and patient B is an older patient, 8-year-old female. So on the right side, they may ask you a question like this on board exam to ask for your diagnosis. So you can see that this patient has a very, very smooth brain. So essentially lack of any gyrus or agyria back here. You can also see that they are almost like just 3 layers of the cell. So you have to the point that sometimes it can be extremely smooth, look like a hourglass or figure of 8 appearance. So that's your classic legencephaly. On the other hand, right here, you can see a broad gyrus. So you have pachygyria in the front. And you can also see there's a linear line of the cortex that go across. So as if there's a benheratopia of gray matter. So this is the benheratopia. So again, seems like a completely unrelated to disease processes by the phenotype, right? So there are certain gene mutations that can affect the outcome of this look. So for legencephaly of LES1, and also known as this long name that I'm not going to pronounce, mutation and DCX mutation for benheratopia. And this is not something new. This is not a new discovery. This back in 1993 from JAMA. They already discovered the LES1 gene that's affecting the legencephaly as a phenotype. There is a sort of a gradient of disease, right? It's more severe in the back toward the front, and this one's more severe in the front to the back. So this is a process that affect the microtubule associated proteins. So this is a nice animation from Harvard. Talk about that's the microtubule associated protein. So the motor protein, they are essentially transporting the protein cargo across a highway that's built up by the microtubule across the axon. So let's talk about the whole category called tubulinopathy, right? So before we talk about, so what is tubulin? So tubulin protein, the main component, you have 2. You have alpha tubulin and beta tubulin, and together they form a heterodimer, and that would in turn polymerize and forming a tube, and is a microtubule. Now, this microtubule is by the way, there's also a gamma that does not participate in formation of the microtubule itself, just sort of anchored toward the back at the place that's called the microtubule organizing center. And the microtubule is a dynamic process. So in other words, they can grow on command. They can elongate and then become shorter, just fairly quickly based on the histology biologic time. So the whole process is dynamic. So microtubule can become longer, shorter, etc. So what is a functional microtubule? And many of you are probably familiar with this or studied this in biology in medical school or pre-med. If you think about the development, specifically deal with neural development, if you think about the 3 main stages of neural development, you have the beginning stage, so you have cellular proliferation, then differentiation. Then the cell will migrate, right? They will have to migrate across the radial glia from the ventricle to the outer cortex, forming a neuron or other supportive tissue. And after that, you have a maturation of the axons and as well as synapse formation. So those are the kind of the main 3 stages of neurodevelopment. For example, if you have not enough proliferation of neuron, you have microcephaly, small brain. If too much, we just look at earlier, you have overgrowth like hemimegalencephaly, polymicrogyria, etc. Turns out microtubule is very important, involving all stage of processes. So for example, in the early stage, the cellular division, the mitosis, that you have chromatid that forms chromosome before they divide. And then the microtubule can form and literally go out and grab the chromosome and then put them apart. Then that in turn will separate into different cells. So microtubule is important to participate in the process of cellular division. And the second stage for the cellular migration, coming from the sort of the ventricular zone, migrate across out to outer layer. And in this modified diagram, you can see that the cell will travel across the radial glia. So starting from the cell developed in the subventricular zone or ventricular zone, they will migrate across the radial glia and essentially go out to the outer layer and differentiate into, in this case, a neuron. So this process is also participated by microtubule. So you have, again, remember the microtubule is a dynamic processes. So they can essentially elongate, shorten, and they will grab the cell and just moving along the radial glia. So that's another function that's microtubule is very important for. Lastly, if you look at the axonal growth and the guidance of the synapse development, the microtubule essentially serves as a highway that allows the protein that I showed you on the animation earlier, the microtubule associated protein, the motor protein, so they can carry the protein cargo across the axon, and that would help formation of the axonal development down the road. So again, microtubule is very, very important for development of all main stages of neurodevelopment. So that's our animation I was talking about earlier. So we talk about the functions, right? You have the mitosis, the cellular development, migration, and the axon development, the three main stages. So what if any of the stage that microtubule go wrong? So what could happen? So for example, during the cellular division, if something affected microtubule, so tubulinopathy, so they may present something with underdevelopment. So you don't have proper cell division. So you're going to have a microcephaly, and you can have a hypoplasia for cerebellar hypoplasia, for example. During the migration, what if something go wrong with microtubule? You can have various cortical malformation. You can have agyria. You can have pachygyria. You can have something that look like polymicrogyria. And during the axonal development, when the axon synapse formation went wrong, you can have something that affect the major white matter tract, such as callosal dysgenesis, the corpus callosum is abnormal, or you can have some other white matter disease, a white matter problem. So you have white matter signal abnormality, brainstem, major white matter tract, also underdeveloped, so you can have brainstem hypoplasia. And you may have a major tract such as internal capsule that's not well formed. So make it look like the basal ganglia is fused. So all those features that can be seen with tubulinopathy, and that's some of the features that would make us think about this is tubulinopathy. We know there are various genes that can mutate affecting tubulin. There's lots, and there's a growing list. It's just that we have challenging to figure out what can the phenotype look like with a particular gene mutation. So the most common one is going to be tubulin A, so tubulin A1A, that account for majority of the case. In this the paper, that they have a much larger patient population, that majority of them is going to affect tubulin A. All the examples that I have over the right are affected with tubulin A. And not surprisingly, because they are the most common subtype. This is a paper with Priya and Cheng Ho back in 2019. They put together a poster, and they talk about a particular gene that may have a certain look, but in reality is that there's a loss of overlap. So it's difficult to predict that based on certain. So therefore, radiogenomic for this malformation is really difficult to do. But the key thing here everybody talk about is that, the thing that would make us think about tubulinopathy, the so-called pathognomonic feature really is the fusion of the basal ganglia. So if you see a malformation that the basal ganglia looks extremely weird, especially if they look like this fused, you cannot see internal capsule. That may be a clue that this could be tubulinopathy. So this is a nice example from this particular paper. they talk about, notice that the basal ganglia right here, you cannot really see a formation of internal capsule. Look like the caudate head is fused with the lentiform nucleus, and you have this bulbous protrusion of the caudate head into the lateral ventricle. So this is a pretty classic look for tubulinopathy, and something that make you think about tubulinopathy. There are other features such as ventriculomegaly and white matter signal abnormality, etc. But that's sort of the key feature here. Another thing is that as I mentioned earlier, because of effect to the white matter tract, many of them also come with callosal dysgenesis. But that's not a very helpful feature, right? Because basically most of this, a lot of pathology malformation is associated with corpus callosal dysgenesis. So, but that's something, the little clue to think about. Other thing that's fairly common is going to be brainstem hypoplasia. And also, if you look at it, there are times that with cerebellar hypoplasia can also associate that because of underdevelopment, as we talked about earlier, various cortical malfunction, sometimes quite severe. And typically you will see also with ventriculomegaly and white matter loss and white matter signal abnormality, as in this case. So let's just go through some of the examples that we have at Riley, and with some of the classic features that make us think that this is tubulinopathy, and it's confirmed to be tubulinopathy. This is a 13-day-old male. You can see on T1 weighted sequence, axial, sagittal, T2 weighted sequence. First of all, you see there's very dysmorphic basal ganglia, fused basal ganglia. Internal capsule is not well seen. Again, this bulbous protrusion of the caudate head into the lateral ventricle. So that's the first clue. Other additional clue, the patient had microcephaly. And notice that there's also a fairly extensive cortical malformation, right? You have pachygyria in the back. You have essentially agyria in the front. Callosal dysgenesis. Cerebellar hypoplasia, and that's another common feature for tubulinopathy. Brainstem also looks hypoplastic. Remember, the pons should be bulbous, and they should be twice the size of the midbrain and the medulla. This one just looks flat and small. And also ventriculomegaly, another common feature for tubulinopathy. So look at the radiology here, then that would make us think that this is tubulinopathy, and sure enough, this is proven to be tubulinopathy. Another case from Riley, from a while ago, it's a 5-month-old, a little bit older patient. Again, first clue, basal ganglia, look fused, internal capsule is not well seen. There are some, this one is a little bit harder to see, not as extensive as the one I just showed you earlier. If you look at, for example, here, you have a little bit thickened cortex with little nodularity, so look like polymicrogyria. So there are area of cortical dysplasia or dysgyria. Corpus callosum looks thin, and the anterior part, the rostrum and the splenium is not well formed. Brainstem also looks small or hypoplasia, and the cerebellar here doesn't look all that hypoplastic like the last case. Another feature that people talk about is that sometimes you can see this asymmetry of the pons with this central cliff, like in this case. That's one feature to look for. Again, patient has ventriculomegaly. Another case from a while ago, 10-month-old female. Again, first clue, basal ganglia looks fused. There are some cortical dysplasia. This one is a little bit harder to demonstrate. Callosal dysgenesis, again. Hypoplasia of the brainstem looks very flat. Again, the asymmetry of the pons with this central cliff appearance is also show up. So this, again, look like tubulinopathy. In this case, you have Vermeer hypoplasia, ventriculomegaly. This one is very recent. This one just occurred a couple months ago. Newly diagnosed. Let's just go through, just reinforce what we see. So what makes us think that this could be tubulinopathy? Again, the first clue, if you look at the basal ganglia, look like the basal ganglia is fused, right? I cannot raise, this is T1 weighted image, T2 sagittal. really not a lot of internal capsule that I can discern, and also looks bulbous dilatation of the caudate head into the lateral ventricle. Ventriculomegaly, that's commonly seen. Notice that there's very, very smooth brain in the posteriorly. So you have a agyria appearance right here. So fairly extensive cortical dysplasia. The look at the brainstem looks hypoplastic, and vermis looks hypoplastic as well. And in this case, you also sort of appreciate that you have these asymmetric ponds with a little cliff in the middle. So this has some of the feature, or many of the feature, that make us think that this is tubulinopathy. And again, it was confirmed to be tubulinopathy. So something to look out for. So if you see some of the features, especially the basal ganglia that's fused, combination of other findings, and think about tubulinopathy. What about the case I just showed you earlier before beginning of the lecture, right? This double cortex appearance, or the benherotobia appearance. So this is a microtubule. It's not tubulinopathy, but microtubule associated protein mutation. In this case, you have pachygyria. You see that double cortex, or the benherotobia. But unlike the tubulinopathy I just showed you, though, typically the corpus callosum, cerebellum, and the basal ganglia looks okay. Corpus callosum looks well formed, and you do not see brainstem hypoplasia or cerebellar hypoplasia. You can, but it's just not as prominent as tubulinopathy. Another case I showed you earlier with lesencephalic appearance, right? Agyria on the back. There's no gyrus. Pachygyria in the front. Benherotobia, again, you can see sort of thickened gray matter. In this case, again, the corpus callosum doesn't look too bad, right? The brainstem is not all that hypoplastic either. So this is more a microtubule associated protein rather than tubulinopathy. So this is one of the older paper by Barkovich, and they look at the difference between microtubule associated protein disorder versus tubulinopathy. And they find that some of the common feature that you see was tubulinopathy. For example, the thin corpus callosal dysgenesis, they find was tubulinopathy majority of the cases, even though the sample is small. Like I said, this is not very common pathology at all, but majority of them does have callosal dysgenesis. Compare that to tubulinopathy, microtubule associated protein mutation. Only minority have that effect. So it seems like more common features such as cerebellar hypoplasia, it affect majority of tubulinopathy, but it's does not affect majority of microtubule associated protein. So again, just something to keep in mind when you next time you come across especially if you see a malformation that has associated dysmorphic basal ganglia, fused basal ganglia, other combination of findings, you can consider tubulinopathy. That is all for this particular talk. Does anyone has any questions? Again, please feel free to email me. That's my email right here. If I have any question afterwards, I will try to answer as promptly as I can. That's all. So hopefully everyone's still awake.
It's always a good lecture, Dr. Wu.
Thank you.
Yeah. Any questions from the trainee? We have about like 20 people in Thailand and neighborhood country watching at the same time as IU.
Great.
Mm-hmm.
Welcome.
Welcome.
So please feel free to email me, especially overseas audience. Also for the trainees, that I do have a little YouTube website that I put some of the cases as well as some of the just general approach MRI physics stuff. And also it's for those who, especially early on in the training, I also have some tutorial for how to read brain MRI, just a basic approach. So you might find that helpful.
I also have the evaluation form on the chat box. So please complete the evaluation form for us so we can know like which one can we do better. Hey, I think Namphon has some questions for you, Dr. Wu.
Sure.
Yeah. As a representative from Thailand.
Okay. I want to ask about what is the most common imaging finding for tubulinopathy?
Your signal is not good, Namphon. Your audio or signal.
I'm
Okay,
sorry.
sorry.
Yeah.
Okay, can you hear me?
I can hear part of it. It's kind of fade in and out.
Okay, I try to ask about what is the most common finding of the tubulinopathy.
For the
To suggest.
I hear that. What's the most common finding for?
I think like she's trying to ask like for the mTOR related disease, what imaging findings that when you see those findings without any history, you can say, oh, this is like a likely to be mTOR.
Right.
And this is likely to be like a tubulinopathy because sometimes we don't have any history, just like an imaging headache or something like, okay, and you can suggest that things on the report.
Right. So for the well, first of all, they are kind of two separate disease categories, right? I kind of just put them together as sort of a underlying theme for radiogenomic. But for mTOR, right now it's still the individual disease or the different phenotype. They are still very characteristic for what they see in radiology. For example, tuberous sclerosis complex had that classic picture that the calcified subepidermal nodule, the cortical tubers, subcortical tubers, and you can see with the sort of the sega if in the location of the Freeman Monroe. So those are still fairly distinct or classic for you look at it and say, okay, that's tuberous sclerosis. And then if you look at other stuff like focal cortical dysplasia, and you see that, say, okay, that's focal cortical dysplasia or hemimegalencephaly that has a specific look that affect a large region or if not entire one side of the brain. So I think right now I think the diagnosis still is made individually. In other words, rather than I don't put in my report say this is consistent with the mTORopathy. I call that this is consistent tuberous sclerosis. So it's more understanding of that there's a common pathway. And then essentially, like I said, that maybe we also lump everything together back again, because maybe down the road, the treatment would be relatively the same, affecting the same pathway. So right now, specifically for mTOR pathway disorder, I don't think you need to worry about like try to tie them together. You just talk about more individual disease processes. So for tubulinopathy specifically is, like I say, it's not a very common pathology. At least we'll see more and more of it, but it's still relatively uncommon. I think some of the key feature that you should be thinking about is the basal ganglia. I think that's a big one. Other type of pathology, I think, for example, corpus callosum dysgenesis, the cortical malformations, those you can see with various other disease processes too. So they're not all that specific. Yeah. So it's one of those things that, and I think the safest thing sometimes still is that there are still many times I look at something that there's many different regions that look abnormal. So the safest thing right now, of course, is just to be very descriptive. Just talk about what you see and maybe sometimes you can put together that belong to a certain disease category, but often sometimes you just don't have a good category to put them in. I don't know if that address your question.
Yes, I think so, because like for the basal ganglia things, it's maybe like the first thing that make you think about tubulinopathy, and then you search more for another findings like a cleft at the pons or other article malformations. Yes.
And this is, in some way, this is kind of the beginning of for radiologists, the beginning of the radiogenomic, right? Still is fairly new. Our standard still is the correlation with pathology. So it's just beginning of it. I think we are getting better and better at it, but still there's obviously a long way to go.
Sure. Any questions or comments from the audience? It seems like you make it clear for everyone, Dr. Wu.
I hope so. It's not. It's a complex topic.
It's a complex topic. Mm-hmm.
I would be completely lying if I say I understand this very well. I'm also learning.
Yeah. So I have the evaluation form for the people at IU to complete, and also for the audience from Thailand. We're gonna send you a link for the evaluation form, and please complete it by Friday midnight to get the CME credit. And for the IU people, you can get the CME credit by send a text message to get to claim the credit. Mm-hmm. Anything else, น้ำฝน?
No ค่ะ okay.
Okay, thank you so much everyone for joining us today, and we will see you, for the lecture series that broadcast to Thailand next month. Last week of the September is about epilepsy, and for the people at IU, we're gonna see you again next week on site with breakfast. Thank you everyone. Thank you, Dr.
Thank you so much.